Welcome, everyone. And I'm sorry more people aren't here for you because I know this is an excellent presentation, but if you guys can spread the word of what it was about. So I have a little script here to read from. Primetime celebrates the learning beyond the classroom of Bethel faculty, students, and staff. And it is a collaborative project between the Friends of the BU Library, faculty development, and other offices on campus. If you enjoy Primetime programming, please consider becoming a member of the Friends of the Library. More information is available on the library website, where in the BU Digital Library you can also find archived recordings of most of Primetime's presentations. So we could show this at a meeting or something, that'd be good. And also coming up next is April 12 at 11:15, Dr. Chris Gertz, Professor of History, introduces us to a lesser known side of a well-known life, the spiritual journey of Minnesota aviator Charles Lindbergh. Oh, interesting. Okay, now I'm going to introduce these two over here. So today you'll hear from Dr. Ann Holland and Dr. Jone Tiffany, both are full professors in the nursing department. This presentation describes the results of a nationwide experimental study conducted to test the effectiveness of a training intervention in producing intra and interrater reliability among nursing faculty, evaluating student performance in simulation. The results of this study inform best practices in high-stakes assessment using simulation and suggest important implications for the design, implementation, and facilitation of simulation reviews for high-stakes assessment. I'm really excited about this work because we do use a lot of simulation in nursing. In fact, the Board of Nursing says we can use half of our clinical time can be simulation. So that's just a new ruling for us. So it's really important that more research is done around this practice so we can do the best work we can. And both of these women have excellent knowledge in this area. So, all right, and I will watch this later.
Thank you.
Do you need this?
No, I got this.
Oh, this thing?
She's in control.
Okay.
Where is she? There she is. Ann. She's in control here. Well, welcome everyone.
Thank you for
Big booming audience here. We are going to talk about the effect of evaluator faculty training and personality characteristics on high-stake assessments in simulation performance. So the team members, you can see here, it's Ann and myself. Ann was the primary investigator, the PI. And then we have other faculty, nursing faculty from St. Catherine University, from a school in Michigan. And then our student worker, she was a master's student, and she's since graduated and now has a full-time job at Normandale Community College. So that's been fun to have her involved as well. And then Joel Fredrickson did our stats. He crunched all of our numbers for us. And so that was quite a feat working with us, trying to figure out what we were going to measure and such. Here's the objectives. We're going to talk about a shared mental model, which is really what we built our simulation research on, and then describe the experimental study design and then the results of the study and implications for nursing. So, background. So before nursing students can become registered nurses, they have to pass a computerized test called NCLEX. So National State Board of Nursing they have a national exam, but it's all in the computer. So many of professions out there actually do a test out at the end, a skills test out. And nursing at this point still does only computerized testing. So we're starting to have the discussion about, should there be a high stakes testing as part of this computerized training? Was studies by the NCSBN, which is a National Council of State Boards of Nursing. It was a longitudinal study that Diane was talking about that they came up with after years of work that we can replace 50% of our clinical with simulation without changing the outcomes. And so schools of nursing are starting to do that because of placements and such. And then the National League for Nursing also did a study on using high stakes testing and interrater reliability amongst faculty. As you all know, I think this is not just nursing that has trouble amongst faculty, that the interrater reliability when you grade papers, when you grade students in their clinical setting and such. So the NLN study had 12 faculty that actually viewed videotapes of student performance, and they were experts in simulation. And they had horrible interrater reliability. And so they waited a year or so, redid the videos, evaluations, still got pretty bad interrater reliability. So what we wanted to do was extend that study and actually see if a training intervention would make a difference, to see if we could get people on the same page. And there's this fair and equitable assessment as well. How do we know if we add this, practical exam, how do we know that we're rating them fairly? And that this faculty might fail this person and this faculty might have passed them, and how do we get that interrater reliability up there? And is NCLEX sufficient, or should we add this piece, to nursing? So here's high stakes assessment. So that's really anything that has to do with academic, educational, or employment consequences. So high stakes, you don't pass this, you don't become a nurse. You have to go back and do whatever it is. And they have these kind of tests in medicine, and they have them in a lot of different professions. Even people who are hairstylists have that at the end of their programs. Now, that's not a life and death kind of job. However, if you've ever had a bad haircut, you might have thought it was life and death. I've walked away with those before. Conceptual Framework is a shared mental model. As you can see here, it's a shared understanding that really helps team members be on the same page. That's kind of what it's all about. And so we thought that was a really good fit with what we were working on with our research. And Ann will talk more about a lot of this in a little bit. So our research design, we enrolled 102 participants from across the country, faculty from across the country, and retained equal numbers in our control and intervention. We ended up with 75. And so we also had faculty who had used high-stakes simulation for testing, and we had some that didn't have experience. And we had the same number of those as well. So we had experience with high stakes, not experience in each of these groups. And they were randomly assigned, and there was no statistically significant difference with the demographics. So we had a demographic survey that had the usual suspects in it, and we collected the age and the education and all those pieces. The Creighton Competency Evaluation Tool is what we used, and that was the same tool that was used in that longitudinal study, same tool that was used in the NLN, the predecessor study that we were extending. So we chose to use that as well. It's a valid and reliable tool to look at competencies in nursing. And then we had 10 video recorded student performance videos, a Clifton Strength Finder inventory. They all took the Clifton Strength Finders, and then we had a Strength Finder survey at the end. The 10 recorded videos, there were many, many videos that they had taken at different schools across the country to use in this study and the previous studies. So we asked for permission and received permission, and so the researchers sat down and we spent many days together watching all the videos, because some of them you couldn't hear, some of them you couldn't see very well, some of them the faculty interrupted the simulation. So they were all videotapes of the same scenario of a simulation, kind of a medical simulation that we ran in a nursing program. So we watched them, we kind of took out the ones that you couldn't hear, that were interrupted, that didn't fit the criteria, and we ended up with low-level performance, student performance, mid-level, and high-level. And we ended up with these 10 video recordings, and then we rated them, and we talked about it, and we worked around a shared mental model ourselves, so that we had something that we could use as the model. And then we had, these were the questions that we had. What were the effects of a training intervention? And then faculty personality characteristics. Multi-methods, and we'll talk about those. Our conceptual framework, and then control and intervention. And so that's how it was set up. Both groups did a basic orientation. They have a couple articles. They did these video ratings, they got the competency definition, so they received all of that, both the intervention and the control group. And then the intervention group had some coaching webinars, evaluation of more training videos, and then remediation if they needed it. So we kept testing their interrater reliability along the way. And we worked with them. Ann and I met with all of them twice for an hour each in groups and worked on this shared mental model. Can we agree that this is what competent looks like in this particular instance? Here's the Creighton evaluation tool. And again, it goes through assessments, communication, clinical judgment, and patient safety. And then at the end, they had to answer, is this student competent, yes or no? And that'll be interesting to hear the results there. And then here is, it was a 0 or a 1 on this tool. And so a lot of the Creighton came with some information that said, this is what 0 means, this is what 1 means. And then we also added our own part to these shared agreements that we came up with. And as you can see up here, gloves should be worn when assessing the dressing. If they didn't wear gloves, they got a 0. So we had these shared agreements when we were watching these videos, because you can imagine they had no context, but the video and the 15 minutes that the student was performing their simulation. They were from other schools, and that's all the raters got is this video, and then this tool. And then here's our clinical competence. This is the same, really the same definition of clinical competence as the other studies used. And as you can see, it's huge, isn't it? We've got professional response demeanor, clear communication, effective interventions, perform the skills correctly. But this is what it looks like to be a competent nurse. And so this was the definition all the faculty who are doing the ratings had. And then they followed that, and then at the end they had to decide, is this end of program nurse student competent to become a nurse or not? Then we had faculty characteristics. We added in, were they comfortable or consistent? We were looking at strength finders to see, are there certain personality characteristics that lend themselves to better IRR, interrater and intra-rater reliability? And what we discovered is more of it, you know, the faculty, when they realized what their strengths were, they made subtle changes. So after the pilot, we ran a pilot in the summer prior to starting, and after the pilot, we made a few little tweaks. We added a strength finder qualitative survey to get more information, and there were a couple things the faculty would say, oh, now I know why I have trouble giving negative feedback, because I have harmony in my strengths. Or they would say, oh, I have a hard time getting on board with this shared mental model because I have belief and responsibility. And I have my certain beliefs that I have. And then you can see here, we analyzed the data using in vivo, and then we triangulated. And now Ann's going to give you the results.
So our data analysis for this study, am I on? Okay, the data analysis for this study was pretty complex. And we really need to credit Joel for working with us through this, because there was a lot of data. There were a lot of stages of analysis in the study. And so I'm just going to show you a snapshot of this and try to move through it pretty quickly. So there were 3 primary analytic steps that we did, okay, kind of distinct processes. And the first one was a calculation of interrater reliability. We computed interrater reliability statistics using ICC and Kappa. Those are 2 different methods of calculating IRR. And one difference is that Kappa takes into account chance agreement, okay? And so it's, even though they should be fairly correlated, they, Kappa sometimes is lower, okay? Their number is lower than ICC. And so this slide shows interrater reliability for the 6 videos in the experimental phase. And it displays the intervention group for the ICC scores and the kappa, and then the control group, ICC and kappa. And for inter-rater reliability statistics, the way that you determine whether you have significant results is you compare it to kind of prescribed ranges, what are recommended ranges for good inter-rater reliability. And so you'll see that in those gold boxes, the ranges for ICC and for kappa. And what we found in this experimental study is that our participants achieved relatively high inter-rater reliability. We're showing you just the total score. So on the CCEI, this Creighton Competency Evaluation Instrument that they used to score each of these videos, there were 16 individual scores for skills, competencies, and then so the total score totaled 16. That was the possible score, okay? And they had to score them. And so the ICC for the total scores, you can see was in the 0.8 to 0.9 values. Kappa is lower because it takes into account chance agreement, okay? But still, still moderate compared to that kappa scale. You see the control group, the ICC is quite high, and the kappa is lower. What impressed us about this is that actually we were surprised that the control group was as high as it was. And so what it kind of said to us was that we, even our basic orientation, which the control group got, helped them to use the tool pretty effectively to get inter-rater reliability. But we see that the intervention group was consistently higher than the control group. So the next slide shows intra-rater reliability. So in this experiment, in the experimental phase of the study, the participants viewed each of these videos at a given time, and then 3 to 4 weeks later they viewed them again, the same videos, and they used the tool to score it again. And so we also evaluated, okay, for each rater in those 2 different times, were they consistent with themselves in rating it? And the numbers are good. We achieved moderate to high intra-rater reliability on each of these videos. And again, the intervention group is a little higher than the control group, but the control group we still felt was pretty impressive, okay? In each instance, the inter-rater and intra-rater reliability statistics that our participants achieved was higher than our predecessor study, that NLN study that first looked at inter-rater reliability, and so we did improve upon their results with the training intervention that we designed. Okay, so then we looked at inter-rater reliability and intra-rater reliability for the yes-no competence decision. Okay, so the CCEI has these 16 competencies and a total possible score of 16, and then the raters had to make a decision. Was the student competent to, enter nursing? And these were the results that we got. Okay, we only used the kappa statistic for this because it's a binary nature of the data, and the ICC, Joel said, was really not relevant for that. And so what you'll see here is that the results for inter-rater reliability here, okay, are much lower for the yes-no decision than it was for the total score. And what surprised us is that the intervention group actually scored lower than the control group in most cases in this situation. So we puzzled about that, why that might be. And as we discussed it, we believe that an explanation may lie in the difference in the cognitive processes that are required for scoring a discrete skill versus making a global competency decision. Okay, so we'll talk a little bit more about that. What you notice for intra-rater reliability is that those were pretty good scores. So they did, they were pretty consistent within themselves at 2 different time periods for that just judgment about the competency. So the results show, okay, seem to speak to us that we were able to shape this shared mental model about the scoring on the CCEI tool, but the global competency decision, not so much. And so we dug more into this whole idea of competency. We really wanted to explore that more. So one of our team members conducted a qualitative analysis of the two rationale that the participants were supposed to give for their yes-no decision. So on that tool, they had to say yes, no, and then they were supposed to say 2 reasons why they said yes, or 2 reasons why they said no. So we decided to look into that a little bit more. One of the things that she found when she really dug into this competency data and she looked at not just the statistics, but just looked at the ratings, and that was, she found that the intervention group seemed to have a harder time saying no, that the student wasn't competent. She found that safety was most often the reason listed as the rationale for the yes-no decision, but the comments that the participants made sometimes were incongruent with the decision that they had made. So for instance, like they would say, yes, the student was competent, but then in their 2 reasons, they'd write about the weaknesses of the student's performance instead of stating, well, the student did well and this and that's what caused me to make this decision. Okay, so it led us to question, is there some cognitive dissonance going on with these intervention group participants, particularly as we were working towards a shared mental model? Because we began the work with them in the intervention group with a proposed shared mental model that had arisen out of the pilot study. And all along the way, as we worked with them, we kept saying to them, is this a reasonable way for us to use this tool and evaluate this performance? And can we agree on this? Is this reasonable? Can we agree? And we reached agreement that they said, yes, we can do this, we can do this. And yet we get to this part of it and we're like, ooh, okay, scoring that kind of worked okay, but now this yes-no thing, they're struggling with that. And so, we wondered, can they adopt and integrate that shared mental model for the discrete assessments, but not so much for the global? Do they still retain personal beliefs and values that kind of at its heart kind of conflicted with this decision about competency? So here's an example of different faculty who said yes. Okay, they said yes, the student was competent. This is for the same student video. Okay, and here's an example. So they said yes, but they had some major issues regarding infection control. Or yes, they said yes, the student was competent, but they didn't complete key assessments, and they moved their leg out of alignment, and they didn't observe standards of patient safety. So it's kind of like, well, why weren't they emphasizing the positive things? Another one, I wasn't impressed with her not using hand hygiene or 2 patient identifiers. Again, these are things in the safety category, okay? Although she didn't wash her hands initially or wear gloves while touching the dressing, she was still overall safe. So that you can see the reservation that they have, even though they're kind of saying, yeah, I guess she's competent. And then, this one, again, same thing. So this is what, our team member found as she was evaluating this, she was analyzing this. This seemed to be still really torn about some of these competing values. So what did we conclude from this analysis? These were some of the things. When it comes to reaching consensus about what competence means, well, how are we being objective, or are we relying still on kind of those kind of feelings that you got, kind of that global feeling about, ooh, I don't know, that really bothered me? Are we seeing that inner conflict? How much of this might have been influenced by personality characteristics? We wondered, okay, in our work with the intervention group in particular to develop this shared mental model, did they want to comply? Did they want to say yes or no, but yet they just still didn't follow it? Or again, this global versus discrete thing. And finally, the comparing, like, are they thinking about past students that they've evaluated, or things rather than this actual definition of competence, and are we consistent with that? So this needs lots of more study. That's what we decided. So IRR, we did that analysis. Then we did this kind of competence analysis, and then the third major analysis that we did was about strengths finders. We really wanted to answer this question about whether faculty personality characteristics had an influence. And so all of our participants took the strengths finder inventory, and Joan computed the top 5 strengths, and these were the top 5 strengths of our participants. Remember, we ended with 75. 75 actually made it through the months of work that this was. And the fact that we had 75 finish is amazing. Because it was it was a huge commitment on their part. But these were the top 6 strengths. And you can see the domains that they fell in. None of the top 6 strengths were in the influencing domain. They were evenly split between the other 3. In contrast, I'll give you a couple strengths that scored very low. The strength of adaptability and activator, they only scored 1.
One person.
One person out of 75 had that. Competition and futuristic, only 2 had those 2 strengths. So I mean, these are relatively high. And then, so what were some of the results of this analysis? Most of the participants thought that the strengths finder results were accurate. They explained, they gave examples of how they thought that knowing their strengths might help in being an evaluator. As I learn more about myself, I feel I can provide more consistent evaluation. And then some participants reflected on how their strengths might actually make evaluation difficult for them. Okay, they might be too strict or too lenient, or maybe they don't like conflict and evaluating is kind of a conflictual thing, or maybe they have trouble being consistent depending on strengths that they have. This is a participant quote from the survey that I think really reflects the big picture of our study. I like building a shared mental model, and I think this is a great thing that nursing departments should create when evaluating students. Rating can be so subjective and scores vary so much between graders. It may be helpful to share one's strengths with the grading team, and then create a shared mental model being cognizant of these strengths as one evaluates students. So I thought that participant really said what we were trying to investigate very well and recognizing some of the significance of that. So what did we conclude? Well, we concluded that the structured training method that we created was useful in creating interrater and intra-rater reliability. And Joel told us he was really impressed with our IRR numbers. He said thought they were very high. And he said, one of the things he said is, you don't always get this with training. Okay, and so we felt really pleased to get that evaluation. One thing that we realized is that those IRR numbers were actually pretty high for the control group as well. And so what we realized is that our basic orientation in itself was a form of training. So you could almost think of the basic orientation as training, and then the intervention group got training plus. It's like training on steroids, and it helped to improve it, but we were pretty pleased with the control group as well. So we really think there's great value in providing a video recorded model evaluation. We actually recorded a description. We showed clips of the training video and recorded, superimposed our evaluation of it, and then we listened to that in the webinar and we discussed it with our participants, and I think that was a really useful tool for helping them to understand how a model gets applied to a student performance. And then we had live discussions on these webinars, and that was, I think, really crucial, that we'd be able to talk about our beliefs, our experiences, our interpretations, so that we can all reach consensus. And in the end, participants had varying degrees of reluctance to accept the shared mental model, but in the end they all agreed that yes, it's not maybe the perfect model of evaluation, but it's acceptable, we can do that. And so I think at some point we have to arrive at that decision together as a team. And then other conclusions, achieving agreement about a complex concept like competence, okay, may be more difficult than awarding scores in, you know, the scored kind of tool. We realize that we need ongoing work. I think teams have to keep working toward that shared mental model and those agreements about competence in particular, because it is such a complex concept. We believe that our results and the reflections of our participants suggest that evaluators really could benefit from reflecting on their strengths and thinking about how they impact their student evaluation. And then finally, I'll refer back to something Joan said. The accuracy of video performance evaluation was highly dependent on the quality of the audio and the video recordings. And we threw out so many videos that were supplied to us by the NLN that they'd used in their study. And we'd watch them and go, I can't believe they used this in their study. No wonder their participants couldn't get agreement. Because like you couldn't see what was going on, you couldn't hear what was going on. And so if we're going to proceed to having some sort of clinical performance evaluation that's high stakes, that says whether someone passes or not, then we have to have very high quality in our recording if we're going to be using videos. So some of the study implications, we really believe that communication and sharing of beliefs and values about competency has to occur, okay? This was actually supported by research we found in other health professional disciplines, where they found that communication was a foundational skill for achieving fair and reliable assessment. It has to be intentional. We have to plan time to get together and to talk about this and to work through these decisions. And that time, there is time that is needed for consensus building. And as I described in our webinars, we didn't have a lot of time. And these were people that didn't work together. They were spread all over the country, right? And so we just, Joan and I, just, you know, we would just say, okay, how are we doing? Is this good enough? It isn't necessarily what you might choose, but does this represent a reasonable understanding of competence? And I think we have to, even with, we always have limited time even in our own teams, so we have to reach that point. Evaluators have to be trained in the use of a valid evaluation tool. It's not going to be valid, the results aren't going to be valid. Even if the psychometrics have been validated, if you're not training faculty how to use them. And that training can help to ensure that, or contribute to legally defensible assessment, and that's really important. And then we believe that the process should include practice evaluations. So like if we're training faculty, we have to give them something to watch so that they can be trained to use it. It can't just all be like cerebral. It's got to be practical. And this is another training component that was shown to be effective in increasing interrater reliability in other health professional programs. So this is supported by other research. So this is a quote from Barry Conchie from Gallup, which is the creator of the StrengthsFinder tool, okay? And Barry says, there's no single characteristic or set of characteristics that would enable us to determine an effective leader. The most effective leaders are the ones who figure out how best to use what they've got. So it matters less what the strengths are in terms of the themes. What's key is that the leaders understand the strengths they have, how those strengths help them to be effective, and that they use strategies and methods to deploy their strengths to the greatest effect. The reason I think this quote is significant is that in the process of our study and in conversations with the NLN and such like that, there's been questions raised about, well, should everybody be an evaluator? Maybe everybody shouldn't be an evaluator. You know, because we don't, like maybe you don't have the strengths to be an evaluator. And yet we realize in programs of nursing, we don't have that option. Like everybody needs to evaluate. We all evaluate. And that's the case in any discipline, right? And so then we have to think about how do we equip people? And how do we help them understand their strengths and realize, okay, I might struggle with this, so I need to be wary of it. This is what I can do to help be the most effective and the most in line with my team. So some implications for research. We know more studies need to be done. Ours was actually the first experimental study that actually, looked at training of faculty for evaluation. And
we're in nursing, so
and
it's
yeah,
really
so it's
just at the beginning.
just the tip of the iceberg here. And so we think lots more. We'd love to see more research being done about personality characteristics and how those influence student evaluation. And then this whole thing about discrete skills versus these global competency decisions, that needs a lot more explanation. Okay, because when you're deciding a high stakes assessment, are you going to base that on a number, or are you going to base that on kind of that is the student competent? That perhaps both factor into it, but we want some consistency there. So, and then Joan likes this quote. So this Navy SEAL says, under pressure, you don't rise to the occasion, you sink to the level of your training, and that's why we train so hard. So we just are really championing training for faculty, and we've seen some benefits of small kinds of trainings that we've done in our own department, and believe that there's much more that we need to do. Questions?
I'm interested in the relationship between the discrete scores of the skills and that final judgment of competence. Are they not related?
Well, we actually, I believe we could, there is some kind of secondary data analysis that we really should do to explore very concretely what the discrepancy was, and we haven't done that yet. But the faculty who led the qualitative analysis of that, she said it was shocking how different it seemed to be.
So
So she believes, she suspects that that okay, because this was our question. It's like, well, is there like a cut score? Like,
Yeah,
if,
there wasn't
like,
a cut score on this tool.
there's no defined cut score for the CCEI. There isn't. They don't make a recommended cut score because it's always going to vary based on how the tool is used and
So
what kind
by that
of.
you mean there's not a score
It's
that
like
says
12 would
if you
give-
pass the score you
Right,
get a
there
competent
isn't. That's not how the
Right.
CCEI is defined. It's not defined that way. And the
Then
CCE.
how is it legally defensible then? If somebody were to challenge the rating, how could you defend it if there
Good
is?
question.
Yeah.
We wonder too. I mean, the thing that I think
They don't
we-
use it for high stakes now.
But there are programs
There
that
are.
are doing high stakes assessment, and Joan and I are very cautious about that.
I'd be pretty
We-
upset if I were a nursing student
Yeah.
and
Yeah,
I were to
right.
hear these results.
So
Right.
one thing that we would, I'd love to do a secondary analysis where we actually look at our 75 participants and analyze, okay, what was the total score they awarded to the student and what was their decision? And see if we can find, is there kind of a general cut score for each video, for each student? We don't know that because we didn't do that analysis. It'd be another round of some quantitative analysis that we didn't.
I realize that that's not, you guys have nothing to do with that decision
Right.
of how that's done. I'm just curious.
Yeah.
Yeah, that's a really good question.
It is a very good question, and it's a question that if nursing's going to move ahead with doing high stakes assessment of clinical performance, we have to answer those questions, because how will we defend, our
Very
decisions?
few schools, most schools are using exams to pass and not the clinical evaluation piece of it.
And if they are using high stakes clinical evaluation, it's not likely to be for like the whole program,
It's not
but it might be,
pass.
course, like for a course, that you might have to actually pass this performance in order to progress on to the next. So we haven't, in our program, we have not incorporated any high stakes assessment using simulation yet. And we don't believe the state of the science is ready for it.
Yeah, good question.
Well, on that line, it seems that the CCEI and the yes or no question are two very different things.
They are.
Yes.
I mean, they're not apples and apples.
And to clarify that, okay, so the CCEI tool, as it was designed by
And validated.
Been validated, doesn't include the yes/no decision. That was a question that was added in the NLN study. Okay, so when they did their first round of their study, and they got such poor iterator reliability, they were trying to understand why. So when they did a whole nother round of it, and they added that competence yes/no and two rationales to it. So, because they were trying to understand, trying to figure out if they could understand better how faculty were making their decisions. And so that competence thing, that's not been validated. But we included it because we wanted to be able to compare our results to the NLN. But our results seem to show it's a really different decision process than scoring a tool. Needs lots more study about how people come to those conclusions.
Do all the evaluators get some form of orientation, like your control group and your intervention group both had that certain?
They were oriented to the tool.
Yeah, but in
So
general.
They got it, they did. I mean, actually.
Your people do, but outside of your group, do other people who evaluate, nurse evaluators get that? It just makes
We
me
don't know
wonder.
what their training is.
Okay.
There isn't a prescribed, there's no national guideline that says that if you're going to do high-stakes assessment in, simulation or something like that, that you have to provide a certain amount of training. There isn't anything
Yeah,
like that.
it's just kind of alarming, though, the implications of if they get no orientation.
Right.
Imagine what their interrater reliability
Yeah.
would be then.
I mean, we were very purposeful about the training that we designed, both the basic orientation. We were very thoughtful, and we researched the literature to find out what kinds of things were recommended, what had been used in the past, and what was documented in other studies. And so we did try to build that on evidence. And we used a professional videographer to create training videos that were part of this orientation and evaluator training. So we maybe failed to mention that we got a grant from the National League for Nursing. And so we worked with them and got permission to use the same tool, that CCEI tool that they used, the same videos that they had produced, and then they gave us, it was a little bit more than $25,000 plus a fair amount of in-kind contributions, because we did offer incentives to our participants. And some of those incentives were things that the NLN actually provided, like a discount on attendance at their national summit and things like that. So they gave us a fair amount of, probably about equal amount of value in-kind contribution to it.
And this is why they still only have a computerized exam for passing the National Council State Board of Nursing exam.
Yeah.
Because we're just on that very tip of the iceberg,
Yeah.
looking at how do faculty rate students? And what kind of training must we have if we move to that? It's a little bit like the AP comp, how they grade those, and they have this pool of people, and they're trained and trained and trained, and they're the only ones that do the rating. So it's probably, we may end up, if it ever gets there.
If it ever gets there to where, like NCLEX, like you have to
Where you
pass
have to have it.
you have to pass a performance to get licensed, I would imagine they'll have to select evaluators for that and do very intensive ongoing training. Because I think this training, whether those agreements have to be reinforced all the time. Other questions? We're presenting next week in Washington, D.C. at the National League for Nursing and Sigma Theta Tau Nursing Education Research Conference, and so we're giving 3 separate things. That's why you saw backgrounds changing a little bit in here, because we were pulling from 3 separate
talks.
presentations to kind of put this whole thing together. We've cut and diced it a little bit for the presentations in Washington, D.C. Going to Toronto in June and Chicago in September so far. So getting lots of opportunity to share the results of our study with nurse educators and nurse researchers, and that's a really great privilege for us. It's really awesome to talk with people who are out there, you know, wanting to answer these questions too. Thank you.